Hi friends, welcome for today's session. It's on NABH 6th edition AAC-10, which is stating about the patient care is continuous and multidisciplinary. So during all phases, qualified personnel should be available round the clock as per the scope of the services. Patient care should be coordinated in all care settings within the organization, and information about the patient care and the response to the treatment is shared among the medical, nursing and other providers. This objective element is stating that the implements of the standardized this standard is stating that the implementation of the standardized handover communication should be there for the all shift, and the policy should be adhered, then referral policy should be adhered, then the organization should have a mechanism to monitor whether any clinical intervention has done for the critical result value. So let us see one by one what is the requirement for each objective element for this. So NABH requirement is that for the AAC-10A, the qualified doctors with the credentialing and privileging for respective scope of the organization to provide the patient care. Personal files should evident the document. Whatever the scope of services is available in the organization as per the scope of services. Each, like if you have the general medicine, then qualified general medicine consultant should be there. Then if you have the gynec, then qualified gynecologist should be there. So and that their qualifications, credentialing, privileging all should be documented in their personal file in HR department, right? This is the requirement of first objective element. Second objective element requirement is that patient care should be on track wherever the patient is, either the patient is in OPD, ward, ICU, HDU, OT. There should be a track of patient record. If in OPD the patient last visited to till visit date, all the records should be there. Either you can do it electronically, or you can do it you can, if you are using the hard copy, then you can scan and you can keep that record for if the patient is forgetting to bring the record. And like consultant need the track of the record. So and patient care should be continuous. There should be no break in the care. So if the patient is forgetting the record also, if you are having in your hand the OPD record, then you can treat the patient. So in OPD also, you can do the digitalization of the record. If you are using the hard copy, you can scan it and file it in the computer, and that access should be given to the consultant so they can open when the patient will visit the next time. And ward, ICU, HDU, OT, everywhere wherever the patient is moving, the patient details, everything should be there in the patient file, and the previous record to till record should be there in the MRD. And the next objective element is stating that patient care should be recorded in patient case sheet by all the care providers. Whoever is giving the care to the patient, they should record their document in the patient file. Where the doctor is coming for the round seeing the patient, they have to write in the doctor's note. Nurse is going and checking the patient, they should write the nurse's note. Dietitian is coming and recounseling the patient, or the reassessment is doing, they should write the dietitian note. Physiotherapist is coming, they are assessing the patient, they are treating the patient, they should write the note. Whoever is involved in the patient care, they have to put their notes in the patient case sheet. Next objective element is patient handover should be done each shift during transfer from other organization, or in between shift any staff exchange happens, then also handover documentation is required. So handover is required each shift, during shift, and you, if you are transferring the patient to any other organization, or inside the organization any transfer from the one unit to any other unit, then also you require the handover. For the handover you can use the S bar. In S bar you can create one column for the transfer in, transfer out also. So wherever the patient is coming and going, you can just write the transfer in time, transfer out time, and your handover note you can put it up, right? During if during shift also, like during one shift, during morning shift, if any patient, any staff has taken the handover, and the staff on emergency she want to move out from the hospital, then she have to give the handover to the other staff. So that also should be documented. in the S bar form. Next objective element is the transfer policy. If organizations should have one transfer policy, all patients should be transferred as per so whatever the patient is getting transferred, that should be documented in the patient file, and handover takeover should be done properly, either intra organization transfer or inter organization transfer. Like any other hospital, you are going, patient is referred and patient is transferred, or inside the hospital only patient is transferring from the ward to the radiology, or any physiotherapy, or any diagnostic requirement, then that should be documented in the patient file. Handover and takeover should be written down in the patient file. Wherever the required, the patient should be accommodated with the staff, and patient should be transferred to the, if unstable patient you are shifting, then doctor also is required to be accommodated with the patient to transfer the patient inter organizations also, intra organization also. So, and if any delay you are getting, like for the that diagnostic radiology has given you the time to transfer the patient at 5 o'clock, and you are transferring at 5:36. So any delay or anything, then that should be recorded, and it should be taken as a QIP, and that should be improved, right? So any delays should be avoided, and there should be an audit actually for the transport delay transportation to avoid. So you can make audit 1 month 2 month audit, you can do it on the transport delay, or at what time has given to the patient and what time patient has been transferred, then you can get a data on that, and you can see the if any delay is happening or not. If any delay is not happening, then everything is perfect. If any delay is there, then you can take that as a QIP. Next is organization should have policy for the referral. So referral could be opinion. The consultant may require the second opinion, or the like patient require the second opinion, or co-management consultant want to do, like uh, patient admitted on general medicine and still the patient required the neuro consultation or cardiology consultation. Then the primary consultant is giving the referral to the secondary consultant, whoever the cardiology consultant or the neuro consultant or anything. So that referral should be documented. Or any, like a patient is under or admitted under general medicine, but patient not required the general medicine care, patient required the cardiology or the neurology, like super specialty care, so patient should be transferred to the other consultant. That case also should be recorded in the patient file, and the reason of referral should be recorded in the patient file. Organization can use one referral form where they can include that reason of referral, or the who is referring to, which consultant you are referring with, date, time, and the reason of referral. Okay, and the reason should, you can mention as a grade wise, you can put it up also, that urgency, priority, routine category also should be mentioned in the referral form. So if the referral is required on urgent basis, or immediately the patient should be seen, or priority wise, or uh, like anytime, whenever the consultant is visiting, just to see and confirm, like that. So that should be categorized, and that should be mentioned in the patient file, in the referral form also. So referral audit should be conducted by the organization to know that how many patient has been attended within the time period. Okay, so NABH, during NABH, assessors will ask you for the referral audit documentation, or are you having, are you have you done any referral audit, or uh, like they will ask you the data, how many patient has been referred and how many patient has been seen within the referral time. So your referral policy should have the defined time frame, like on urgency means 5, within 5 minutes or 10 minutes the consultant should see. Immediate means immediately, like the time with line should be uh, defined. Priority within 1 hour or 2 hour, priority based they can see it up. Routine category, okay, fine, within 24 hours referral should be seen. So that you have to see the grade wise, and you have to see that it is met or not met. So like that you can create one audit checklist, and you can do the referral audit. Then uh, you can produce the document to the NABH assessor, so you will not get the NC, right? So policy should have the time frame based on the category. So next is the documented turnaround time and service schedule are communicated to the patient or family or caregiver at the time of registration, admission or initiation of care as applicable. So TAT should be defined for all the services, wherever the how much time will require for the admission, how much time required for the discharge, if for the any service required or a diagnostic, how many, what is the waiting time, or OPD, what is the waiting time. That should be defined. In the event of any anticipated or unanticipated delay, that should be communicated to the patient or patient caregivers. Okay. And any compliance within the defined timeline is monitored periodically. For this also audit needs to be done for the TAT delay or waiting time delay, or if anything is there, then you take as a QIP and try to fetch the TAT. Right. So the timeline you should define, each department shall define and document the turnaround times, such as the registration time. What is the registration time? So 5 minutes you have defined in your policy. Then consultation waiting time should be defined in the policy. Okay, 5 to 10 minutes or 15 minutes. That should be communicated to the patient. Laboratory report that should be defined. Radiology report that should be defined. Admission processing time should be defined. Discharge summary preparation time should be defined. Medication dispensing time should be defined. So these are the timing you should define, and you should put in your policy. Next is that the AAC-10 has next objective element is telling that the following requirements should be recorded in the patient file. So patient details, so this is like critical value should be informed, and intervention needs to be taken on the critical value. So what is the required to be recorded in the patient file? The patient file should have the patient details, critical value, time results generated, time communicated, name of person informed, and time of clinical intervention and nature of intervention taken. You can make a seal or the sticker to put in the patient file which is having these are the details, and you can so anyone can write there. So, and you can make that as a red color, so it will be very easy to get it up, right? So then the intervention taken should be written. This is the major requirement, that whatever the critical value has been identified, for that intervention should be written by the clinician. If intervention is not written, that you will get a NC on this, right? Either it will be OP basis or it will be IP basis, both where it is required. OP, how you will do it? For the OP patient, you will report to the consultant, and consultant will take a action on that. But cardiology department, they have to do the 360-degree, either OP or IP, when they are reporting the like ECG, echo, or your TMT. These values are, they have to report to the consultant, and they have to ask the consultant that what is the clinical intervention for this patient has taken, right? So that also they have to do the follow up, and they have to write it in their critical register book. So this is the 360-degree, whatever intervention till the time critical value produced to the consultant till and the intervention taken is your 360-degree for the critical result, right? So this is very important to be implemented in the hospital. So it's required for both IP and OP patient, right? So thank you. If anything more required, then just do the comment on the comment section. I'll get back on that. Thank you so much. If you like, please do the subscribe.